Thank you. I'm happy to be here. Thanks, Dr. Mohammed Al-Amri and Dr. Ashraf Armia to invite me for this wonderful conference. As Dr. Yahya Salah said, we are back to the basics. So we are speaking about talk about the capsulorhexis, the most important part of the cataract operation. We have to look carefully because maybe it dictates how your operation will go. So in this case, we can find that even if you're using a cystotome or even a pharynxis forceps or crocodile forceps, you have to look carefully about the insertion or of the filaments, or we can see some filaments is stretching. So I have to change my hand and so see some of the zonules just attached anteriorly. So you have sometimes you can't, if you don't see well, so sometimes it mislead you and make an extension for your rhexis. So how much is stretching in the capsule? The capsule can be stretched up to 60% more than its diameter. If you have a 5 millimeter, so you can extend it up to 8 millimeter. Maybe in this video we can show how strong, if you have a young patient, how strong is the recoil of the zonules and how much. We can repeat it again in a slow motion, so we can see how much is the power of the zonule. So it's your third hand. It just hold it like this, but sometimes you can, if you have an old age patient, you might not find this recoil maneuver. So the capsule is also like a Sullivan. So if you have a regular or a circular rhexis, it's very difficult to open it. We can see here, I have to click it. Click. This click means that you just cut. You have to make a very small cut, and then you can continue if you want to enlarge the rhexis. So the ideal rhexis should be circular, well-centered. We are talking about the manual, we are talking about the basics. So what we want is to prevent anterior displacement of the lens and an expected myopic outcome, preventing the phimosis, allow sufficient room for easy phaco, and also you can rotate. If you have upside down lens, you can rotate it, so you have still a big or more or less capacious rhexis. So one of the basics that when you even inject the viscoelastic, be sure that you inflate and you just inject and you fill the anterior chamber. That makes your straight surface of the rhexis of the capsule, so you can easily maneuver. Also, when you're doing if you're using a cystotome, it's better to not be vertical. It can be obtuse, so you can see the tip. Like here, now you can see the tip. If you use it in a vertical way, so you can see the edge of the rhexis, so you can control it more and more, like here. And also you have to make a little bit curve, so you not press on the back of the posterior lip of the wound. So this is maybe the ideal if you can use it, or you have to be careful, making just a small snip, trying not to disturb the cortical matter, not to lose the contrast, making like stations step by step from the area of the nearest part, so you can control it. If you find it wants to run away, so you can complete it in this way. Also, even if you don't have a viscoelastic, you can use it on a saline with a filled anterior chamber, like here. Maybe this is not we don't use it too much, but sometimes I can use it in a such way. So you just depend on the floating of the rhexis in the anterior chamber, and you can complete the rhexis. Also, when you're using your rhexis forceps, maybe you have to start with the curved one, because if you use a straight one, it presses on the posterior lip of the capsule, so you can find some of the viscoelastic is coming out. But this one is a curved one, so you can manipulate in the anterior chamber without pressing more and more. So even if you start with the rhexis forceps without cystotome, you have to take a small snip. And also, as we said before, you don't have to disturb the cortical matter, and make it in a stepwise. Like here, you can control the wideness, and you can control the circularity, and you can control the size. Even if you have the extension, in the past they said if you have extension, you have to make you can withdraw to the central part. No, just when you tract against the extension, not toward the center. This is against extension. You can continue even if you don't see the edge of the rexus. So maybe in some cases, like you have to understand the type of the cataract you are working with. Like here, this is a hypermature cataract. Sometimes we do it's already having its hydrodissection, so we do irrigation aspiration before the phaco. So it's making normally hydrodissected. But if you have an pearly white intumescent cataract, this is the blockage of the pathway. So here, like here, so when you just open the anterior capsule, the nucleus is pushed forward, and you can find the Argentine flag sign. Like this case, you can find it. Once you touch it, you will open it. It's exactly like the Argentine flag sign. So how can you manage this? Going with a spiral rexus, you have to be sure that you have the air bubble complete. If you have more than one air bubble, that means you didn't empty the anterior chamber from aqueous, then you're not filling it well. So I used to inject the stain under air. Don't wash the stain, just inject viscoelastic like here, and then continue the case like here in a spiral way. Very small, very small. Then when you find it just extend, you can continue. Sometimes you need it to cut it more and more because sometimes it gets around the rexus forceps. Then you can continue this. Also in the calcified one, also the same. You have to obey that the junction between the calcified lens, the calcified capsule and the normal capsule, you have to be sure that the clicks as we thought about.
Okay, just continue. Okay. Please continue.
Thank you. And then you can continue. In such case, you have to cut all the calcified part, and still you can continue, because this is one of the important step. Like here, using more and more viscoelastic, taking the steps, you can use the cutting until you can catch finally you can continue it until you have a complete rexus like this one here. So even you can find that we have a late Argentine flag sign. Why we can have a late Argentine flag sign? Continuing the case like here, but we didn't cut well the calcified part as here. And then we complete the rexus, and when we rotate, you find this is an extension. Just with the rotation, that we call it the late Argentine flag sign. We can see it here with the rotation and the opening of the rexus. So conclusion: no matter what new instrumentation or surgical techniques become popular, the anterior rexus will continue to be an important part in cataract and the lens-based refractive procedure. Thank you.
Thank you so much. I think couple of points I need to discuss with you. One is the last case you were showing about especially when you're operating with the Morgagnian cataract.
Yeah.
So we just started working on something called, before the procedure, massaging the capsule. See, when you take a blunt needle, you go inside the AC after putting the sufficient viscoelastic. Try to massage the entire capsule.
Yep.
So there will be within the capsule, the fluid, there will be even distribution of the fluid. Otherwise, sometimes what will happen in the Morgagnian cataract, when you put the incision, straight away it go for Argentinian flag sign. Once it is gone for Argentinian flag sign, then different issue altogether. But before putting the incision with the blunt needle, 26 gauge needle, massage the entire capsule so that there will be even distribution of the cortical fluid within the bag.
But maybe in some cases of Morgagnian cataract, you have a small lens.
Yeah.
So it's not the pearly white intumescent cataract. This is the most important. That's the one that you're talking about. Just massaging. But the problem is there is a blocked pathway. The nucleus is very large, and the pushing is coming posterior. Even if you evenly spread the cortical matter, still you have a pressure behind. So it should be careful. There is no 100% guarantee that we will not face an Argentine flag sign, but there is a 100 method to trying to not to face it.
Yeah,
Maybe.
and one more thing, whenever you are having Argentine flag sign also, one of my friend described something called flap motility sign.
Yeah.
So with the flap motility sign, if you look at the flap motility sign, if at all, if it is extend also, if it's towards the the center side,
It's inverted or inverted there, that's right.
then you can still continue the phaco. And the last take home message, I think in pediatric, always be better, since the capsule will be very elastic, better to use the forceps than with the cystito.
Thank you.
Thank you.
Thank you.